Hi, everybody, and welcome to part 2 of our lecture series on hip conditions. It really doesn't matter which order you listen to these 2 lectures. My name is Jim Moeller, and I am the director of the Sports Medicine Fellowship at Henry Ford Health System in Detroit, Michigan. The goals of today's talk are to review the common musculoskeletal conditions of the hip encountered in athletics, and this is in an adult population. The pediatric hip issues are covered in the pediatric lecture series. We want to talk about presentation and exam findings, as well as discuss the appropriate diagnostic imaging options that are available for different disease processes and review treatment decisions. Today we're going to talk about femoral neck stress fracture, pubic ramus stress fracture, osteitis pubis, different types of hernia, and briefly discuss obturator nerve entrapment. Don't forget, when athletes come in with hip pain complaints, you also have to consider the lumbar spine and genitourinary conditions as a potential cause of their pain. So without further ado, let's get started in discussing femoral neck stress fractures. It is reported that femoral neck stress fractures account for 1 to 7% of all stress fractures seen, but the incidence is unknown. It's more common in females and certainly more common in runners. These injuries are reported commonly in both civilian and military athletes. The pathophysiology is repetitive loading from impact load activities leading to micro bone cell damage, which is the initiation of the process, and this eventually leads to the stress fracture, which is the propagation of the process. When you talk about femoral neck stress fractures, you have to think about the way the ground force and the body weight force affects the femur. And from this, you can create both a compression side or a tension side stress fracture. When you look at the body weight force and the ground force, the inferior margin of the femoral neck is being compressed together, and that would be a compression side injury if it takes place on the lower aspect of the femoral neck, whereas the uppermost part of the femoral neck is being forced into tension, or it's being bowed apart, if you will, and this is a higher risk area for injury. Again, the compression side stress fracture takes place along the inferior margin of the femoral neck, where the tension side is being pulled apart on the superior aspect of the neck. The history includes insidious onset of hip or groin pain, and it can be fairly vague. The onset is often noted after a recent change in activity level. It is worse with impact load activities such as running and jumping, but may become painful with daily activities. Generally, it improves with rest. Certainly, in female athletes, we need to be on the lookout for the relative energy deficiency in sports syndrome, or the Red syndrome female athlete triad. On physical examination, you may notice a limp. You may create tenderness with palpation. You may find painful range of motion. You may find pain with strength testing and/or weakness. But the examination is often vague. In fact, the examination may be normal at rest. The patella percussion test is an interesting clinical tool when examining someone with fractures in the hip. The examiner places the stethoscope at the pubic symphysis and then percusses the patella on the injured side. If the femoral neck is intact, the sound will often be very firm, whereas if there is a fracture, sometimes there is a vibratory nature to the sound, bzz, bzz, something like that. Imagine tapping a broken baseball bat on the ground, and that vibratory sound is something that you might hear in someone with a hip fracture. You are certainly more likely to hear changes on the patella percussion test in someone with a full-on fracture of the femoral neck than someone with a stress fracture. But when someone comes in with an appropriate history and physical examination, x-rays should be obtained. And oftentimes they're normal, but you're looking for cortical thickening, periosteal changes, or a frank fracture line. Bone scan can be helpful, looking for increased uptake in the femoral neck. The problem is that sometimes you just see uptake in the femoral neck, and it's hard to determine whether it's actually on the compression side or the tension side of the bone. It's very important to differentiate between these two. An MRI may be a better follow-up test, looking for marrow edema and a fracture line, because again, the specificity is quite high in determining the difference between a compression or a tension side injury. Here's an x-ray of a patient of mine that walked into the clinic, but I did not allow her to walk out of the clinic. She was complaining of hip pain that began roughly 3 weeks after increasing her running activities for preparation for a half marathon. And you can see in the left hip, there's a clear fracture line coming from the superior margin of the femoral neck, extending about halfway through the femoral neck. Here is a bone scan that shows increased uptake in the femoral neck, and it certainly appears to be on the inferior margin or on the compression side, but it is somewhat difficult to tell. Here is another bone scan image that shows increased uptake in the femoral neck, and again, probably on the compression side, but difficult to tell. Sometimes you can pick it up on whole body imaging. As you can see, there's certainly something going on in the right hip, but to have more focused images is very helpful. On the MRI, you can see on the slide on the left, increased marrow edema and a fracture line coming through the compression side of the femoral neck, and you can see this even on the T1 images on the right-hand side as well. If it's a compression side injury, these tend to be more stable. Pain-free weight bearing is allowed, but if they have discomfort with weight bearing, then some type of assistive device should be used. No impact load exercise is allowed. You institute pain control measures with medications, ice and heat. It's helpful to maintain range of motion and strength in a pain-free manner, either with a home exercise program or formal physical therapy. And after there's been resolution of the discomfort and an appropriate amount of time has passed, and they have a normal exam otherwise, a graded return to exercise in a pain-free manner is allowed. On a tension side injury, you make the patient non-weight bearing immediately, which is why I didn't let that patient walk out of the office. And you refer them to orthopedic surgery for consideration of pinning. So again, here's the x-ray of the patient that I showed you earlier, and here she is 24 hours later. Pubic ramus stress fractures are considered to be quite rare, but again, they account for 1 to 7% of all stress fractures seen, just as we talked about in the femoral neck. They tend to be more common in women, and certainly most common in the inferior pubic ramus. High-risk activities include distance running, and military recruits will have this injury quite frequently as well. In a systematic review published in Military Medicine in 2011, 11 articles from a military population were compared to 10 articles from an athletic population. 6 of the articles in the review did not discuss specific location, only calling them pubic/pelvic stress fracture. The data that you see on this slide only considers studies in which pubic ramus pelvic stress fractures were reported. You can see that females were at a higher risk for this type of stress fracture compared to males, and military females certainly had a higher risk than civilian females. If you go ahead and add all of these numbers together, you come out with just over 6% of the stress fractures encountered in military and athletic individuals were in the pubic and pelvic region. If you simply add all of the remaining stress fractures from the studies that did not report specific locations, then you end up increasing the denominator significantly, even though you don't increase the numerator significantly, and the incidence decreases to 3.6%. The history of a patient that you need to consider for pubic ramus stress fracture includes someone with insidious onset of hip or groin pain, and again, it can be fairly vague. But again, onset is usually after a change in their activity level, worse with impact load activities, and improves with rest. This is a duplicate of the slide from the femoral neck stress fracture that we just talked about. Again, the examination can be quite vague and is often normal at rest, and so imaging can be very helpful. Just as we talked about with the femoral neck stress fractures, on x-ray you may see cortical thickening, periosteal changes, or a frank fracture line, although I find that in the pubic ramus this is relatively uncommon. A bone scan may show increased uptake in the pubic ramus, and again, an MRI can be very helpful due to its increased specificity. Last fall, as we were approaching marathon season, I had 3 patients in 1 week present with pubic ramus stress fractures. For treatment, you need to let the patient know that they should expect healing to occur over 8 to 12 weeks. You want to get them into a situation of pain-free weight bearing, even if this includes giving them an assistive device or taking them off weight bearing on the injured side for a period of time. No impact load exercise is allowed. Pain control measures, as we discussed before. Pain-free maintenance of range of motion and strength is important. And after they have a resolution of their pain and an appropriate amount of time has passed and they have a normal examination, a pain-free graded return to exercise program can be initiated. Osteitis pubis is an irritation of the pubic symphysis from repetitive microtrauma, most commonly seen in runners, but also can be seen in kicking sport athletes or due to repetitive adduction-abduction activities. Childbirth can also cause damage to the pubic symphysis region and osteitis pubis. The prevalence is thought to be around 0.5 to 6%, but the incidence is unknown. When you look at the anatomical structure of the pelvis, the black portion listed as number 5 would be the pubic symphysis. The dotted line is the linea terminalis, which is the pelvic brim or edge of the pelvic inlet. It's important to remember that each side of the pelvis moves independently at the pubic symphysis, which can create shearing forces superiorly and inferiorly, as well as compressive forces. And in this space, there is an interarticular disc, which is very similar to the intervertebral disc that you see in the back. An interesting autocorrect in this slide, I apologize. Each side of the pelvis does not move indecently at the pubic symphysis. It's independently at the pubic symphysis. I left that in because I frankly didn't notice it until now, but it's an interesting autocorrect, don't you think? When we look at the anatomy, there's a great deal of muscular attachment in the region. The adductors, the rectus abdominis, the pectineus, and ligamentous structures also abound. The athlete with osteitis pubis will often present with vague anterior pelvic or groin pain, which is worse with activities, especially impact load activities or repetitive adduction-abduction activities. The pain is typically improved with rest. On clinical examination, they'll have tenderness over the pubic symphysis in most cases, but they may be tender over the pubic rami, which makes you need to consider stress fracture in this region. Pain is often noted with resisted adduction, and their strength may be reduced due to the discomfort. Occasionally, when you're testing this, a click or pop may occur in the pubic symphysis as well. Hip range of motion is typically normal, but may cause anterior pain with adduction. Neurovascular status is usually intact. Typically, x-rays will be obtained at this time. Certainly, an AP pelvis should be obtained. You're looking for sclerosis, osteolytic changes, bony spurring, diastasis, and degenerative changes at the pubic symphysis. Bone scan will show increased uptake, but with the bone scan being so sensitive, but with low specificity, it'll be hard to tell whether it's osteitis pubis alone or if there's a pubic ramus stress fracture. An MRI can be helpful looking for bone marrow edema without evidence of stress fracture. Here's a bone scan, and again, it's difficult to tell if that's a stress fracture or osteitis pubis. Here on MRI, you can see the increased signal in the bilateral pubic symphysis region with slight cystic formation present. Conservative management is effective in most cases with rest activity modifications anti-inflammatory medications, ice or heat, and rehabilitative exercise. Corticosteroid injection has been used for a long time, but there is really limited evidence as to its efficacy. Surgery with wedge resection, curettage, or arthrodesis can also be performed. The CHOI study, published in the British Journal of Sport Medicine in 2011 out of Ohio State University, was a systematic review of 195 athletes, 186 of which were male. In the review, there were 4 case series with report of injection as part of the treatment. This subset of patients included 30 patients in total, 26 of whom were male, with an average age of nearly 25 years. On average, these patients received 1.24 injections, but no one received more than 3 injections as part of the treatment. 17, or 58.6%, of these 30 patients were able to fully return to sport at 8 weeks post-injection. 20% had absolutely no response to the injection whatsoever. In the Burn study published in 2017, there were 45 patients with MRI-diagnosed pubic symphysis disorders who received fluoroscopic guided injection. 44 of these 45 patients were males with an average age of 29. 89% of the patients experienced initial symptom improvement, but only 58% had sustained relief beyond 6 months. That's the same percentage who were able to fully return to sport at 8 weeks post-injection in the CHOI study. Back to the Burn study, only 5 of these patients had isolated osteitis pubis, and of that group, 2 had total pain relief, 1 had partial pain relief, and 2 had no pain relief. I recently read a paper describing a single case of a patient with isolated osteitis pubis who was treated with PRP injection. And the single PRP injection was successful in helping relieve this person's pain. This case has not been published. Let's move on now to hernia. When you talk about hernia, what we're going to focus on are the inguinal hernias, both direct and indirect, femoral hernias, and sports hernias. There are many, many other types of hernias. A hernia is simply a tissue or organ that protrudes through an abnormal opening in its usual container. Most commonly, we're talking about inguinal hernias when we use this term in sports medicine, although femoral hernias, abdominal hernias, diaphragmatic, muscular hernias, disc herniations, brain herniations all can occur. 75% of groin hernias are inguinal hernias, and certainly more common on the right side and more common in males. 600,000 inguinal hernia repairs are performed annually. Again, the predominance is 9-1. The highest incidence of inguinal hernia takes place between the age of 40 and 59. Interestingly, overweight and obesity may be a protective factor for people when you talk about inguinal hernia. The United States Preventive Service Task Force makes no recommendation regarding screening exams for inguinal hernia. They give a D grade recommendation for testicular cancer screening in adults and adolescents. And the hernia check is not performed as part of a standard PPE unless history is suggestive of hernia. Certainly, if the athlete is having their physical done at their medical home, then this is something that can be more easily performed. Many times, pre-participation physical examinations are being performed in a group setting or in a gymnasium setting where it just doesn't lend itself to appropriate hernia screening. But again, hernia screening has not been shown to be of significant benefit. Hernias may be asymptomatic and can be found incidentally on physical examination. And what do we do in that situation? If it's asymptomatic and it's incidental, oftentimes we're just going to follow that patient anyway. Patients with pain due to a hernia will usually describe an insidious discomfort if it's a slowly enlarging hernia. If they have sudden pain in that region, it's usually due to a sudden heavy strain where there's either incarceration of that hernia or strangulation of that hernia in a previously asymptomatic patient. The description of pain is often vague and usually localized to the area of the herniation. It is worse with activities which increase intra-abdominal pressure, such as lifting or straining with Valsalva, cough, sneeze, and bowel movement. A bulge may be described, but oftentimes is not. On physical examination, you need to inspect for lumps and bulges in the inguinal region, and this is best performed with the patient standing. And you want to do this both at rest and with Valsalva. And you also want to palpate for the hernia using scrotal invagination, either with your pinky finger or index finger, whichever you're most comfortable performing the examination with. An indirect hernia will travel through the inguinal canal and strike the examiner on the tip of the finger, where a direct hernia will come through the posterior wall and hit the examiner on the edge of the finger. So the indirect hernia comes through the internal ring, into the canal, and out the external ring. It starts lateral to the epigastric vessels. The direct hernia comes straight through the posterior abdominal wall and is medial to the epigastric vessels. Imaging is not often needed, but ultrasound is an excellent initial diagnostic imaging tool with a high sensitivity and specificity. MRI of the pelvis is more helpful in looking for changes consistent with sportsman's hernia, and a CT of the pelvis can certainly distinguish between inguinal and femoral hernias, but is usually not necessary. When I am suspecting hernia based on history, I do tell the patients that sometimes on physical examination, I may not be able to feel a hernia even if one is present. If physical examination findings are significant for hernia, then no additional diagnostic workup is completed. If I am suspicious but don't feel the hernia, then typically I will order an ultrasound of the inguinal region at that time. We want to avoid the complications of hernia, including incarceration, which is entrapment of the herniated tissue. This can lead to bowel obstruction and certainly significant increase in pain. Eventually, the herniated tissue can be strangulated where there is vascular compromise and can lead to death of the tissue. Treatment of an asymptomatic hernia that's found incidentally is observation. The risk of incarceration over the next 2 years is only 0.3%. But if a patient has a symptomatic hernia, then surgical consultation for repair is recommended. Let's talk about femoral hernia. These account for 4 to 10% of groin hernias, and it's more common in elderly women, 3-to-1 ratio to males. It often presents as bowel obstruction in that age group. And I'm not going to get into any more details about femoral hernia. It tends to be fairly uncommon in the athletic population. I do want to spend some time on the sports hernia, which to me is the hernia without the hernia. So everything sounds like a hernia and leads you to believe that a hernia is present, but a hernia can't be palpated. And typically, diagnostic studies show no specific hernia as well. The true incidence of this problem is unknown. It is certainly more commonly diagnosed in males. Patients eventually diagnosed with sportsman's hernia or sports hernia typically present with groin or inguinal pain of insidious onset, which is worse with activity and better with rest. Typically, they will have failed treatment for adductor or hip flexor strain before they present to you, or you may treat them for adductor or hip flexor strain several times before you come to the diagnosis of sports hernia. Unfortunately, with return to sport, they usually have a rapid return of their discomfort. Gastrointestinal and genitourinary symptoms are uncommon, and lumps and bulges are also uncommon as a historical component. Interestingly, testicular discomfort may be described in up to 30%. Dr. Myers, who is considered one of the sports hernia gurus of North America, reported on 20 years of experience in treating these injuries back in 2008 in the Annals of Surgery. He looked at nearly 8,500 athletes on which he had operated. The number one sport associated with sports hernia was soccer when you look at the entire series. However, over the final 2 years of the series, football had actually overtaken soccer as the number one sport. On physical examination, there are generally no visible lumps or bulges, Valsalva may cause discomfort but not create the lump or bulge. There should be no palpable hernia, although the testing for hernia may be uncomfortable for the patient. Hip range of motion is full. Strength testing may reveal discomfort and weakness, which is why oftentimes patients are diagnosed with hip flexor or adductor strains. The examination is often unremarkable at rest. Imaging is generally used to rule out other pathologies, and there are multiple imaging techniques which may be utilized. The problem is, it appears that the pain comes from a weakness in the posterior abdominal wall, even though the wall has not given way. So none of the abdominal contents are technically herniated from their normal position. Because of this, diagnostic studies may show changes that aren't specifically due to the pain from a sportsman's hernia. In the end, the diagnosis is clinical based on excluding other things, and the final diagnosis is confirmed at the time of surgery. People suspected of having sports hernia are usually treated with conservative management, including physical therapy. The majority of patients who undergo surgery will be able to return to their full sport. Initially, women only comprised 1% of the surgical patients in the Myers cohort. At the end of the study, they comprised 15%. Initially, 100% of the patients were classified as athletes, and at the end, it was roughly 77%. One would think that if sports hernia is a consistent and predictable pathologic entity, that the surgical intervention for sports hernia would be the same surgery. Dr. Myers reported on 26 different surgical procedures and 121 different combinations of procedures in his 5,460 patients on whom he operated. This tells us there's a great degree of variation in what is found. Athletic pubalgia is probably a better term to use compared to sports hernia. It has been reported that there are up to 20 non-ball and socket joint soft tissue structures which may be involved in the primary pain production of people presenting with pubic-related sport pain. In an MRI study in 2006, looking at 100 consecutive MRIs of patients who presented with athletic pubalgia, it was noted that pubic symphysis defects were noted in 93%, rectus abdominis defects noted in 76%, and adductor longus defects were noted in 46%. We certainly have much more to learn with regards to athletic pubalgia and sports hernia. Obturator nerve entrapment is an interesting process. This is one of those situations where it's probably seen me, but I've never seen it. I can honestly say I've never made the diagnosis of obturator nerve entrapment, even though I've considered it on several occasions. The obturator nerve comes from the L1 through L3 nerve roots and descends within the psoas muscle into the pelvis. It then passes through the obturator canal into the medial thigh compartment. It divides into anterior and posterior branches, which are separated by the adductor brevis muscle. The motor innervation is to the adductors. Sensory innervation is to the medial thigh. So again, sensory innervation in the medial thigh region, where the motor innervation is to the adductor musculature. Patients with obturator nerve entrapment may present with insidious onset groin pain, which is described as a deep aching pain centered on the adductor origin at the pubic bone, and it's worse with exercise. It may radiate down the medial thigh towards the knee, but rarely passes the knee. The athlete may tell you that they have weakness that is related with exercise, especially when they're attempting to jump. So the more they exercise, the weaker they become. Paresthesias are rarely present, but may be present. On physical examination, they may or may not be tender at the adductor origin. Range of motion of the hip joint is usually normal. At rest, they may or may not exhibit adductor weakness. Medial thigh sensory changes may be present, but again, that's a little bit more unusual. So the exam at rest is often normal. It could be helpful to have the patient exercise and re-examine them to see if weakness starts to set in after the onset of exercise. But in general, the examiner must have a high index of suspicion to make the diagnosis of obturator nerve entrapment. X-rays are used to rule out other pathologies, as are MRIs. The MRI can certainly reveal adductor atrophy in situations of obturator nerve entrapment. An EMG will show a denervation pattern of the adductor longus and brevis, but this may not become positive for several months, and so an EMG could be disappointing when the history and physical exam all point to obturator nerve entrapment, but the EMG returns normal. Conservative treatments can be attempted, but often have disappointing results. Surgical neurolysis is often necessary to relieve the symptoms of obturator nerve entrapment, with patients able to return to sport within several weeks. So to recap, there are many causes of hip and groin pain in athletes that are not directly related to the ball and socket joint or surrounding musculature. A high index of suspicion is needed to determine causes of hip pain in athletes, and certainly be on high alert for stress fractures, particularly in runners who have had recent changes in their training programs. Inguinal hernias are more common in males, where femoral hernias are more common in females, but by far inguinal hernias are the most common type of hernia noted in the inguinal region. And certainly sportsman's hernia is not well defined, and we have a lot more work to do in trying to figure this entity out. I appreciate your time and attention on today's lecture. This concludes the two-part series on hip problems in the adult athlete. I hope this was helpful for you, and I look forward to meeting you someday.